Will be Dr. Heather Cheng, who is an assistant professor at the University of Washington and assistant member here at Fred Hutch. And her research has really focused on understanding hereditary predisposition to prostate cancer. And she has recently opened a high-risk clinic that's at the SCCA. So Heather's going to tell us about a particular study that will help all of us in the state of Washington understand this predisposition and learn for ways to deal with it. Heather?
Okay, thanks. Can you all hear me in the back? Okay. If you can't, just wave your hand and I'll try to adjust accordingly. So, yeah? Oh, no, you cannot hear me. Can you hear me better now? All right. I'll try to speak up a little. Is that better? Okay. Okay, so I thank Pete and the organizing committee for the opportunity to speak here. This is my second year speaking about genetics. And some of you who were here last year and the year before may have heard some of these slides and concepts before. And so what I'd say is you already know much more than many of our colleagues that we're trying to educate around the country. And those of you who've heard this for the first time, hopefully you'll take a few tidbits away. So I'm going to talk about inherited genetics and then towards the end talk about this exciting study called the Germline study. Let's see here. All right, so here's our roadmap for the next few minutes. I'll first talk a little bit about something we've known for a long time, which is that prostate cancer is one of the most heritable cancers, meaning if you have a family history of, for example, a brother or an uncle or a father with prostate cancer, that automatically increases your risk of developing prostate cancer. That means for all of you who are prostate cancer patients, this is important information for your sons and nephews. But what we've also sort of realized is that that's not enough. It's important, but it's not sufficient. We also need to be thinking more broadly about the family history of other cancers. The women in the family, for example, are there women who have breast cancer in your family? Are those women, did they get those diagnoses at a younger age? Is there ovarian cancer? Is there breast cancer? Are there other cancers? These help us inform what the risk factors might be for prostate cancer. And we now have a better understanding of the association with certain genes that are relatively rare in the population but are enriched in people who have more aggressive cancers. And those are genes that I'll talk more about, such as BRCA2 and its family of genes. And then I'll talk a little bit about the prostate cancer biology that we know is associated with BRCA2 briefly. And then most importantly, I think, is how can we use this information to help patients like you and your families and other patients and families. And then I'll end with talking about the Germline study and how hopefully it'll become clear from the earlier part of the talk why that is impactful. Okay. So, the inheritance and risk of cancer is really only one part of the risk factors, and I think Dr. Neuheiser is going to talk about diet and lifestyle, and there are as well environmental factors. So that's not what I'm going to focus on. I'm going to talk about genetic factors. And even among genetic factors, there are common factors that are present in many people in the population that might confer a small risk. And when we add those together, they lead to the final risk of any person's likelihood of developing cancer. And on the other hand, there are more rare variants or more rare genes that one could inherit that make enough of a difference in somebody's risk that we might intervene or do things differently and manage that person's risk even more differently. Here's a slide that I think it's important to think of, to emphasize, which is what we talk about when we talk about genetics. And genetics, sort of broadly speaking, refers to, I think, DNA and genetic material of both what we are all born with, or what was inherited from our mother and our father, and that's inherited genetics, or germline genetics, as you might hear it called. And that's DNA that's passed from parents to children and generally are present in all cells of the body. What that means is that those variants in genes are found in every cell of the body, the healthy cells, And those can indicate a higher risk of cancer. And so in some cases, we know of certain genes that are called cancer risk genes, or also called cancer predisposition genes, and those increase your risk of cancer. They don't mean you will get cancer, they just mean your risk might be higher, and maybe if we knew about it, we might want to do something differently about that. We can also test these from just testing your blood. Because again, they represent all the cells in your body. So we can test that from a blood test, or sometimes a saliva sample, because your cheek cells are going to reflect the same DNA. So if you spit into a tube and we are able to collect the DNA, we can assess what you inherited from your mother and your father. Now, this is related to, but not the same thing as what's cancer specific, or sometimes called tumor specific or somatic genetics, which is the cancer that is in the genetics of the cancer, which may have originated as your cells that you were born with, but then acquired or picked up mutations along the way that allowed it to become aggressive and develop into a cancer. So there are cells that originate from the original blueprints, as I call it, the genetic blueprint, that then picked up maybe some errors in the Xeroxing that then led to a different working copy in the cancer cells that lead it to not have, the plans lead it to be poorly behaved and more aggressive and behave like cancer. So those are picked up in cancer cells. They're not in all the normal cells, and those would not be passed on to kids. So cancer risk is passed on, but cancer itself is not. So again, just to emphasize that the cancer risk, not the cancer, is what's inherited when we're talking about inherited or germline risk. And we can test those either in the blood or in, for example, saliva samples. So it's also important, and many of you have heard me talk about this before, really thinking about the family history of cancer, because that can sometimes give us a clue that there may be an increased risk. So for example, we're all fairly comfortable and familiar with the fact that having a family history of prostate cancer is important, but this is my slide to remind you that, if to the extent that you're able to learn and ask your families about the cancers, if there are cancers, and the details of the cancers among brothers and sisters, mother and father, grandparents, aunts, uncles, cousins, and really ask deeply, at your family reunions, at the next, barbecue, and share that information to the extent that you're comfortable, because this is valuable information. More specifically, knowing what kind of cancer, if anyone had more than one kind of cancer, what age they were approximately when they were diagnosed with their cancer. Was it 50? Was it 80? That makes the difference in thinking about whether there might be an inherited component. Any details you might be able to gather about the aggressiveness of the cancer. Did they have Gleason 6 disease? Did they have Gleason 10 disease? Those are not the same thing. Or grade group 2 or 3 versus grade group 5, as the new classification is going, that Dr. Reeder is going to tell us about. If they're no longer alive, did they die from their cancer, or did they die from some other cause? So those are useful information pieces that you can gather both for yourselves but also share with your family members to sort of compile what the family risk might be, and is useful for doctors to think about what the likelihood is of a genetic risk. So I talked a little bit about genetic effects on cancer risk and that they're not equal. There are, actually I should update this now, as Dr. Nelson said, average risk for the average person is 1 in 9 for men. And then there are common mutations or common variants, as I mentioned, that might increase your risk or decrease your risk by a little bit. And then there are these more rare genes in the population, but which are important, like BRCA2, which is rare by itself. But when there is the presence of a mutation in a gene that runs in the family like BRCA2, it increases the risk quite a bit. So instead of going up or down 1 step or 2, you're actually going up a floor or maybe even 2 floors of risk. And so thinking about that, if you know the risk is that much different, we might be able to intervene and perhaps think about strategies like what Dr. Etzioni was talking about, and maybe studying whether or not it makes sense to do screening earlier, at an earlier age, and or at a more frequent interval. So those are things we can study and begin to learn more about. We know from data in the past, largely from breast and ovarian cancer, which is how we first identified these genes, that BRCA2 mutation carriers, people who have inherited one of these mutations, then go on to develop prostate cancer, have more aggressive disease and a higher likelihood of dying from their prostate cancer. So this is something we've known about and provides an opportunity. We also know that the risk of developing prostate cancer in carriers is about 5 or 9-fold higher, and other cancers are also implicated, such as male breast cancer, pancreas cancer, melanomas. And these are historically, as I mentioned, associated with more aggressive prostate cancer and worse prostate cancer outcomes, but that's historic. So this is, today in 2018, and I don't have time to talk about it today, but I think something that you should be aware of is that when we know that there's a mutation like this in the advanced disease population, I'm a medical oncologist, so when we're treating advanced disease, we have better tools. If we know that somebody is a BRCA2 carrier, their toolbox expands. And that's really exciting. So I won't go into all those details except to know that that's another reason why it's important to find men who have these mutations. And looking forward, even though we know that the prostate cancer outcomes were not as good in the past, the ability to use this information to tailor our early detection, tailoring our screening strategies, designing new strategies to improve the chance of cure once we find cancer, if we can find it earlier because we understand the biology better, and adding highly effective precision treatments to the therapy toolbox. These are drugs like PARP inhibitors, which are in clinical trials right now, as well as platinum chemotherapies, not things we would normally think about for prostate cancer, but we do in these settings, that I think we can envision a dramatically improved outcome for patients. And so I think we'll really change the natural history by knowing more about these genes and finding them. Okay, so this is a real quick mention of a study that we were fortunate to be part of that was published now a couple years ago, where 700 men with metastatic prostate cancer, regardless of their family history and regardless of their age of onset, were found to have a number of important gene mutations like BRCA2. So 12% of them almost had inherited, so those germline mutations that they inherited either from their mother or their father, with genes in this family, and 16 genes were represented. The majority of them were this gene, BRCA2, but then there are some others that we're also learning about, ATM, CHEK2, BRCA1, that are inherited, that may confer increased risk of cancer, and also may improve or expand the treatment toolbox in the advanced disease setting. So we know more about BRCA2, less about the thinner slices of the pie, and we're currently working on trying to understand those better. As I mentioned, when BRCA2 mutations and that family of mutations, although they're not all the same, we're still learning about them, may result in some treatments being exceptionally effective. This is what's really exciting in my day-to-day practice or weekly practice in my medical oncology clinic, because we now have new options, these PARP inhibitors and these platinum chemotherapies that appear to be very effective and so are very, very exciting. The way they work, and I've talked about this in the past as well, but just to briefly mention, they take advantage of the weakness of the cancer as a consequence of not having the BRCA2 mutation. It's sort of like an Achilles heel. When you know what the weakness is, and those mutations lead to a higher level of background error in the cancer, the drugs actually force additional error in such a fashion as the cancer cells cannot go on. Okay, so additional potential impact. When we're looking for the 1 in 10 men with advanced disease who may have an inherited DNA component, and because of the inherited nature, siblings and children may also be at risk. So 50% of children and siblings could potentially carry the same risk gene, and we could intervene by either screening them differently for their cancer and treating them in a fashion that's more tailored. So there's a number of barriers to genetic testing. Just really quickly, knowledge and awareness, access to genetic services, cost and insurance coverage, And we do have this new prostate cancer genetics clinic at the SCCA. Many of you, I see in the audience, have been to that clinic to talk about some of these concepts in detail and more sort of for your personal case. And I do want to talk about the Gentleman study. So Gentleman study stands for Genetic Testing for Men with Metastatic Prostate Cancer, and the main objective is to remove barriers and determine if this is an acceptable delivery of genetic care that may provide important and critical information for men with metastatic prostate cancer as well as for their families. And the aim is really to offer genetic testing, germline genetic testing, to every man with metastatic prostate cancer in the state of Washington, so that there should not be barriers to finding out this information that may be important. It's web-based, it's patient-driven. There is a patient survey, family history, knowledge, behaviors, and distress. Patients can upload their supporting data. We can also help them from the research team side. So if this may be something of interest to you, there's going to be cards outside at lunchtime. And essentially, once that's completed and we verify eligibility, patients are then mailed a saliva kit that's actually a colored genomics kit. And the costs are covered by the study. They receive their results by email. If there are no findings, then they receive them with a genetic counselor if there are, and they're invited, of course, for additional research opportunities. This is the current map as of a few weeks ago of the people who are have participated, and we are expanding outside the state of Washington. So here are the take-home points. Genetic testing is increasing. We're actively trying to maximize the benefit to patients and their families. A complete family history is important, but it's not enough. Prostate cancer screening should be guided by a family history of cancers and increasingly also informed by genetic risk. The Gentleman study is available for men with advanced disease, and there are many research and clinical trial opportunities for men with BRCA1 and 2 and related mutations with prostate cancer that are very exciting. And we do have the genetics clinic and prevention pathway that are resources for patients and their families. And there's my email, the appointment number, and then the website for the study. And again, there'll be cards outside during the break. So thank you for your attention.
Thank you, Heather. So our next speaker is Dr. Marion Neuhauser, who is a member here at Fred Hutch, who